My name is Gail Hausman. I'm a registered nurse, and I am employed by the ALS Association Greater Philadelphia chapter for the past 18 years. So I just work with folks that have ALS. And I am here today along with two of my colleagues to talk about what is ALS, its treatment, and how the chapter, the ALS Association Greater Philadelphia chapter, can help people that have this illness. So I'm going to start with objectives, which you're free to read. I don't usually like to read the slides. And then we're going to go into the definition of ALS that I wrote a long time ago, and I don't believe it's changed since. So amyotrophic lateral sclerosis, otherwise known as ALS or Lou Gehrig's disease, is a fatal, progressive neuromuscular disorder that causes eventual paralysis of all voluntary muscles. So in this country, it's typically called Lou Gehrig's disease, named after a very famous baseball player who died from this illness a long time ago. All over the world, it's called ALS, amyotrophic lateral sclerosis, or motor neuron disease. I have the word fatal in there because the average life expectancy after diagnosis is 2 to 5 years. So most people who get diagnosed with ALS die within the 2 to 5 year range. So that's about 90%. So that means that some people live longer, and some people, unfortunately die sooner. Very important word in this definition is the word progressive, because ALS progresses all the time. It could be a very, very slow progression, or it could be a rapid progression. So it usually involves, usually starts in a limb, either an arm or a leg, that's weak and gets weaker. And, unfortunately with this illness, eventually people become paralyzed from the top down to their toes. Okay? So ALS starts in the frontal section of the brain. I'm just going to show you a picture of that right here. And it involves the motor neurons, or motor nerves. The motor nerves are what is connected to our voluntary muscles. And what happens is the motor nerves die, and therefore the muscle, the voluntary muscle that it's connected to, dies with it because it's not getting stimulated. If you think of the motor nerves as being the almost like the juice or the electricity or like the thing that gets the muscle to work. So I'm using my arms right now to talk, and in order to do that, I'm getting stimulation from my motor nerves to the muscles in my arms. And that's the only way that the muscles will work. So what happens is the motor nerves die, and therefore the voluntary muscle eventually dies. So people with ALS can become paralyzed from, here to the bottom. And unfortunately, the voluntary muscles also include our speaking, our chewing, and our swallowing muscles. So eventually people can no longer speak, chew, or swallow. And again, unfortunately, it also involves the breathing muscles. So people can no longer breathe on their own. The diaphragm is the main muscle that we use to take a breath in. The lungs don't work without the diaphragm. So the diaphragm gets us to take the breath in, and that muscle also becomes, eventually affected by ALS. So that means that muscle becomes weaker and eventually stops working. So respiratory failure is the usual cause of death, or the leading cause of death with this illness. So this diagram, I just want you to see, as far as I keep talking about the signal. the motor nerves send the signal down into the spine, and then there's all these motor nerves that shoot out to all of the various muscles. The motor nerves that are in the brain and the spinal cord are called the upper motor neurons. The motor nerves that are shooting out to the muscles are called the lower motor neurons. So these are all of the muscles, all of the voluntary muscles affected by ALS. Some of them are, not. Start over again.
Yeah, it's okay. You can just start whenever you want. I'll just keep recording.
So these are all of the voluntary muscles that are eventually affected by ALS. So the obvious ones: arms, hands, legs, feet, chest, abdomen, the back. So if you're taking care of somebody who's lost their back muscles, you sit them up and they're going to plop. The neck, eventually, the muscles in the neck die. So then this is how their head is going to be. The throat, the mouth, and the tongue is a voluntary muscle. So a lot of times you're going to be seeing people that have what they call dysarthria, or maybe even anarthria. Dysarthria being trouble speaking, anarthria meaning that they're not able to speak at all. And a lot of that has to do with the tongue muscle that isn't working. The face, you'll see drooping, and the diaphragm and other muscles that we use to take a breath in. So ALS occurs all over the world in every culture. It's slightly more common in men until the age of 65, and then it equals out, and they don't understand why. About 5 to 10% of all people with ALS have what they call the familial form of ALS, which means that it runs in families, that it's a definitive genetic problem. And if you have the familial form of ALS, your biologic offspring will have a 50% chance of inheriting the illness. Okay? It can occur anywhere from later teens to the age of 90 or into the 90s. We actually have seen people who were diagnosed like later teenage years, and we've had people diagnosed into their 90s. The prevalence of ALS is about 6 to 100,000 people on average. So prevalence, which I always get confused with incidence, prevalence means the number of people that have the illness at any period of time. So in the United States, it's roughly 6 per 100,000 people. The incidence means the rate of new cases in a period of time. So the incidence is about 1 to 2 per 100,000 worldwide. Okay? There have been reported clusters of ALS, which means greater than 1 to 2 per 100,000, and I'm going to get into that in a little bit. So a person with ALS, usually it takes them a little bit to get diagnosed, because it usually just starts as like a weakness, and people think, it could be anything. But as the weakness progresses, hopefully the person has seen their primary care doc, and that person has sent them to a neuromuscular specialist, who is a neurologist who specializes in motor neuron illnesses. So with ALS, in order to get diagnosed, there has to be a history of progression, which could be very, 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 where you can barely see it, and then sometimes it's, it's much steeper. They do a whole bunch of blood work, CAT scans, MRIs, to make sure that it's not something else. A trained neuromuscular specialist can pick up certain signs on exam. So I talked about the upper and the lower motor neurons, or nerves, and they can pick up certain signs that indicate problems with both the upper and the lower motor nerves. And an EMG has to be done, which is when they stick needles into the muscles, and they can tell if there's lower motor neuron degeneration from that. So they have to have all four of these factors in order to be diagnosed with ALS. There's three other illnesses that are related to ALS, and they fall within the umbrella of our organization, the Greater Philadelphia Chapter. The first one is called PLS, or primary lateral sclerosis. And these folks have problems with the motor nerves in their brain and spinal cord, but the nerves that shoot out are okay. These folks tend to live a lot longer. They have more trouble with spastic muscles, with tight pulling kinds of muscles, or feeling that way, feeling as if the muscles are in spasm. With these folks, you may not see any change in their in how they look as far as their muscles go. You don't see the wasting, the muscle wasting that you see with ALS and with the other two. PMA is progressive muscular atrophy. So these folks have problems with the motor nerves that shoot out of the spine that are connected to the muscle. It means, therefore, that the brain and spinal cord motor nerves are fine. So these folks have problems with cramping, which is different than a spasm. A cramp is like a Charlie horse kind of pain. And these folks, you're gonna see the muscle wasting. Both PLS and PMA are better diagnosis as far as prognosis goes, because these folks tend to live longer. And just from what I've seen over the years, it seems like especially people that have the PLS. There's something called progressive bulbar palsy. So the bulbar muscles are our speaking, swallowing, chewing muscles. And what happens with these folks is they have upper and lower motor nerve problems, meaning the brain, spine, and the ones that shoot out, but just to the bulbar muscles. So these people have trouble, speaking, chewing, and swallowing only, but their arms are okay, their chest, their back, sometimes the neck gets involved, and their lower extremities are fine. Unfortunately, this one seems to be a little bit of a faster progressor based on just from my own experience. It seems like it eventually progresses either to the arms or to the breathing muscles, but it could be years before it does that.
Whenever you're ready.
So possible risk factors for ALS. Smokers have a higher rate of every illness, it seems like, and if you smoke, you have a higher risk of developing ALS. Age, the older you are, the more likely the chance that you'll develop ALS. So ALS most commonly occurs, is diagnosed roughly between the ages of 50 to 70. If there's a family history of ALS, you have a higher risk of developing ALS. And also, regarding the military, anybody that has served in the military for any period of time from World War II on up, any branch of service, whether or not the person saw active combat or not, has a twice as likely risk of developing ALS. And they don't understand why. ALS does not affect involuntary muscle. So any of our organs that are covered by involuntary muscle are not affected. Okay, it doesn't affect the bowel and bladder. However, most people have trouble with their bowels. They usually get constipated because they might be losing their muscles here to push, and also their diet has changed, their mobility has changed, so that's kind of a common occurrence. Bladder, for whatever reason, it could be because of spasms in the bladder, but a lot of our folks have urinary frequency and urgency. It doesn't affect sexual functioning because it doesn't affect the senses. And I get asked all the time, what's the difference between ALS and MS? And I don't understand MS, but I do know that MS, in addition to affecting the motor nerves, also affects the sensory nerves. So with MS, you can have sensory changes. With ALS, people can still smell, taste, see, hear, and touch. So they still feel both pleasure and pain. It is very, very rare for our folks to get bed sores, because when they're sitting on their butt for a while, they can feel it, and they, when they'll let you know, hopefully. It's the people that are basically can't feel anything are more likely to develop bed sores or decubiti. So when I started working for the chapter 18 years ago, they told me two things. Initially, I was told that one, there's no pain with ALS, and that is absolutely inaccurate, because people can develop or have both spasms and or cramps. They can have the pain that's associated with immobility, which is sitting in the same position for a while, and they can also develop like numbness in their lower extremities, and we believe that that's secondary to immobility also, if their feet are always hanging down low. The other thing that I was told is that there's never any cognitive impairment with ALS. And then, I don't know, 5-6 years later after I started, they said, no, that isn't true, that roughly 50% of all people with ALS have some cognitive impairment, and that usually it's mild impairment. So what they're saying is about 50% have no cognitive impairment, about 50% have some cognitive impairment, but it's more in the middle, meaning it's mild. The extreme of the cognitive impairment is called frontotemporal degeneration. And roughly 5 to 10% of all people with ALS also have something called frontotemporal degeneration. So FTD. FTD is a problem with either behavioral variant, which is what they call it, which means that the person's behavior is out of character. Very often they have disinhibited behavior, show poor judgment, decreased or lack of empathy for their loved one. They might do things that are really out of character, like gambling or some type of addiction that they pick up. So we had a lady who would shop every day and order things, and the delivery truck would come every day, and every day the husband would send it back. We had another woman who went to Atlantic City and bet everything, her house, her pension, everything, lost it all. And it happens with men too. They were just the two that came to mind. And then there's the executive functioning part of FTD, which is more like processing data and being able to multitask. So we had a CPA who had this, who was unable to balance his checkbook. And then the other section would be the temporal section, which is language. So not language related to bulbar muscle problem, but language problems related to processing language. So either these folks have trouble saying a word that they want to say, or the word that they say is nonsensical. Okay? So the most common variant as far as the frontotemporal degeneration is the behavioral variant. Okay? But again, most people have milder forms of what I just described, and sometimes the families, they don't see it, they don't see that there's a problem, and we sometimes suspect that there is a problem. This type of cognitive impairment is part of the dementia umbrella. So dementia's up here, and there's different types of dementia. So FTD is one type. Most people think of dementia as Alzheimer's, which is primarily memory. That's a different type. And then there's other types of dementia. But with ALS, the most common would be the FTD. The Association for Frontotemporal Degeneration have listed on their website, and their research indicates that people with ALS people with FTD are about 10% of those folks develop ALS. Okay? So that means that there's a genetic link between FTD and ALS. So they really do not understand what causes ALS. There's all different kinds of theories. They're looking at problems inside the motor nerve, outside the motor nerve. They're looking at muscle problems. They're looking at all kinds of things. And they don't have it's not like a one answer. They believe that there's a genetic predisposition for the illness and that something triggers the motor nerves dying. Okay? With the familial form of the ALS, which they know is genetic, so far they've been able to identify up to 70% of the genes involved. Okay? So what researchers say for both the sporadic, which is the more common, meaning that it doesn't run in families, and the familial, is that there's a complex interaction between genes and the environment, and that triggers the motor neuron death. And also aging. So treatment options. We have to talk about treatment options throughout, at least I do, throughout my time working with people who have ALS or PLS, PMA, and PBP. So there's really two different schools of thought. There's more palliative, meaning palliative means basically to treat symptoms, to treat problems. And then there's more aggressive. And by that I mean eventually with ALS, the chewing and swallowing muscles die, and people have to decide, do I want a feeding tube? And the next thing that they have to decide, usually, at different times, not always, is my breathing muscles eventually are going to die. My diaphragm is going to stop working. So do I want to have a tracheostomy and invasive mechanical ventilation that does the work of the diaphragm? So that's a ventilator. Okay? Most people elect to go the palliative route, but there are some people that say, I want whatever I can get to stay alive, and that's their right. There's two FDA-approved drugs that have been shown to slow the progression, both modestly as far as I understand it. The first one came out a while ago in the 90s. It's called Riluzole. It's very expensive, so if you don't have coverage, some people don't take it if they're not covered. They believe that Riluzole, they believe that it's involved in decreasing something called glutamate that sits outside of the motor nerve that they think is damaging the motor nerve. However, the studies, from what I read, roughly 3 to 6 months to maybe a year slowing of progression, and then it stops working. Okay? And with Riluzole, you have to have your liver checked because it can damage the liver. So you have to get regular blood work. The new drug that's been out for the last year or so is called Radicava. In Japan and South Korea, it's called Edaravone. And it was just FDA approved in this country over the past year. I believe it was actually in August of 17. It's a drug that's given via a port, so you have to have a port put in, and you get the drug for, I believe it's 10 to 14 days. You get the drug, and then you're off for 10 or 14 days, and then it's repeated for 10 or 14 days, and you're off, and it's on and on and on, and that's for the rest of your life. It's very expensive. It's about $150,000 a year. Most of the folks that we work with who would like to be on Radicava, their insurance company approves it, but not 100%. It is so far covered by Medicare for the patients that have definitive ALS. Okay? So I talked about palliative managed symptoms. So what are the symptoms? So a big symptom for just about everybody is fatigue. Because let's just say your legs are weak. it's going to be so much harder for you to walk. So you're going to get tired. So what we talk about is energy conservation, spacing out activities so that they're not doing like one thing after another, getting help with activities of daily living. So for instance, if my arm, the shoulder is weak and I'm trying like the dickens to get my hair brushed, and then my arm is so weak that I can't feed myself, I would say to the caregiver, why don't you brush the hair and let the patient be able to feed themselves? So that's what I mean by helping with ADLs. And then conserving energy for what's important. So if you're having trouble speaking and you're having dinner with family friends at night, you might want to conserve your voice for when your family comes over. Energy conservation to me is kind of like common sense. Okay, with as far as home health aides or CNAs, we encourage these folks to not push this particular patient. Don't push them if they're not up for getting out of bed or whatever it is. Okay, because we want to conserve the energy. It's different as far as the rehab world goes, because in rehab you're trying to get people back on their feet. With ALS, we're trying to conserve what energy they have. So mobility, regarding mobility, range of motion and stretching are what's important as far as PTOT and what the caregivers can do. We want to keep the joints moving, and stretching can help with both spasms and cramps. So, just a little thing about stretching. Hold for 20 to 30 seconds, perform 3 to 5 repetitions daily. So caregivers can be taught by PT and OTs how to do the stretching. And it says cannot increase muscle strength, but can maintain muscle length with stretching. So if you have a weak limb, let's just say my right leg is weak and there's atrophied muscles, wasting in the muscles, I'm not going to build up the muscle by running on a elliptical, okay? But what I can do is maintain the length of the muscle and help with the spasms or cramps. Okay, the thing to keep in mind with ALS, again, is that the disease is progressive. So if you're working with somebody who's still able to walk or still able to move their arms, or their neck is nice and, holding it up straight, eventually all of these muscles die. We also talk about adapting activity. So I've already mentioned energy conservation. We talk about modifying the home. A lot of times, in particular regarding the bathroom, it's nice when a person has like a first floor setup with a handicapped bathroom, but not everybody can. So sometimes we have to talk about just using a commode if they're not able to get up the stairs. At times, some of our patients can use a stair lift to get up if there's a bathroom on the second floor and none on the first. We have to talk about driving. We have to talk to patients about accepting help, because a lot of people want to do things on their own. I would too if I had this illness, but that's something that we need to address. And we talk about positioning to increase efficiency. So some people with ALS start in their bulbar muscles. So they might, early sign might be a change in voice quality, that a loved one would say, hey, your voice sounds funny. And then some people have, by the time that they die, don't have any trouble speaking. They might have decreased breath support, meaning their breathing muscles are not involved in projecting their voice because they're weakened. So no matter what the issue is, if a person has trouble speaking, there's all kinds of devices out there, very, very simple devices to computer screens that are set up in front of your eyes, and you move the mouse by moving your eyes back and forth. Okay, that would be the kind of the fancy, expensive ones. And then there's simple ones, like this is called a board, a letter board. These are for yes or no words. So I would say to the person, move your eyes to the right for yes and to the left for no. And I would say is the first letter of the first word on the first line. So that means it's one of these, A, B, C, or D. Is the letter A? Is the letter B? So I'm moving my eyes to the right, means that it's a B word. And a lot of folks are smart and they write down B words like bathroom or, I don't know, beverage or whatever. And so then you would just go through the list. Is it a bathroom? Do you need to go to the bathroom? Do you need a beverage? Whatever. Okay? This is very slow, especially in the beginning, but usually what happens is caregivers are able to figure this out and sort of whiz through it. This does require, though, for the patient to be able to move their eyes to the right or left. Okay? Sometimes people blink instead, but from what I understand, the movement to the right and left is usually the better way to do that. And then there's something called a boogie board. So for people that can still write but can't talk, they can just use the stylus and write what they want. And with the styluses, you can get these adaptive pieces of equipment that will make the stylus thicker. So if you have decreased range of motion in your fingers, it'll be easier to write with. Okay. Some people use iPads exclusively to communicate. There's all kinds of apps that you can upload. We do talk about having some sort of call bell or alarm system. So if you have a patient in one room and the caregiver in another, some sort of call bell with the patient maybe can move, like with their head or maybe on their feet, so that the caregiver can get to them. Some folks use actually baby monitors so that they can hear their loved ones. We have a communication specialist, a nationally known communication specialist on staff, Elisa Brownlee, and she can be consulted for any communication related issues. So for people that have trouble swallowing, some people elect to have a feeding tube, which we call PEG. And then people that have some, like, minimal trouble swallowing, we talk about chin tuck. So the further your chin down, the better. Chewing food slowly, concentrating on chewing and swallowing versus, a lot of times people sit around and talk, they might have food in their mouths. That's a no-no. Our folks who have trouble chewing and swallowing do better with smaller, more frequent, higher calorie, higher protein meals. And then avoid foods that are two different consistencies, like a vegetable soup. They do better with more of a pureed or like a pudding kind of, or a bisque. And then everybody who works with the patient should know the Heimlich maneuver in case of choking. People with ALS pretty much all develop breathlessness at some point, and they may also have orthopnea, which is trouble breathing and lying flat, feeling like they need to sit up in order to breathe. Okay? So early interventions would be to raise the head of the bed with pillows or with whatever, energy conservation, and then we use almost exclusively now something called a trilogy, which we recommend for people with ALS who have problems with this. And a trilogy is kind of like a CPAP machine that people use for sleep apnea, but it's more involved. So basically, people with ALS who have this would wear some sort of a mask. It's either a mask on the nose, a full face mask, or little pillows that sit inside the nostrils. It's connected to a tube that goes around the head and to a box about this big. And the trilogy senses when you're taking a breath in, and it helps the diaphragm to take a bigger breath in. So it's an assistive device for the diaphragm. It also adjusts accordingly. So if you're laying flat, it's actually harder for the diaphragm to move, so it gives you more air then. It gives you more help. And as you sit up, it gives you less help. Okay? It's almost always covered under health insurance. The other thing that we talk to people about is avoiding people that have colds, infections, because a lot of our people with ALS develop like a respiratory infection because they picked it up from somebody, and unfortunately that can go into pneumonia. Some other problems that people have as a result of ALS: secretions. So if you don't have your muscles here working well, here you're going to have drooling. We all have saliva in our mouths. If you don't have the muscle strength to swallow it, it's going to come dripping. Here you're going to have mucus. We all have mucus in our throats. Again, if you're not able to clear it, if you don't have a good cough, it's going to just sit there. So we have different, we have medication for both. We use nebulizers for the mucus, and we use something called a cough assist, which helps to stimulate a cough for the mucus. There's a symptom called pseudobulbar affect, and that's a definitive symptom of upper motor nerve problem, and it is uncontrollable laughing or crying. So something will set a person off, a person with ALS off, and they can't stop laughing or crying, or both. And that's actually a treatable symptom. There's a very good medication for that called Nudexta that helps with that. Laryngospasm is a sudden, an acute feeling that your throat is closing up, and that's due to a spasm in the throat muscles. That's also a treatable symptom of ALS. I talked about pain, both cramps and spasms. There's pain related to immobility. It's very common for our folks to get depressed, as you can imagine. There's one loss after another with this illness. It's very common for caregivers to get depressed. And that's treatable usually. We pretty much always recommend both therapy and medication if that's the case. And insomnia is common for all kinds of reasons. Depression, pain, breathlessness can cause insomnia. So our people with ALS, our patients that have ALS, have very difficult decisions to make. Do I want the invasive mechanical ventilation, which is the vent, no vent? Do I want the feeding tube, which is PEG, no PEG? Where am I going to live? Who's going to take care of me? How am I going to pay for everything? I lost my job. I can't work. Equipment. How am I going to afford all of the equipment? How am I going to afford the co-pays? How can I get out of the house? If I have a power wheelchair, how am I going to get anywhere if I don't have a van? The fact that they're dealing with what we consider to be a fatal illness, and on top of it, there might be some cognitive impairment. So I just want to end with, or at least my part, with, again repeating that the disease is progressive, that the person will eventually, get worse. And people that can't speak are not necessarily having trouble with dementia. It would be the muscle impairment that's keeping them from speaking. So we need to assume that they're completely alert and oriented times 3.
Hi, my name is Janie Eskovitz, and I'm a social worker, part of the Patient Care Services at the ALS Association Greater Philadelphia chapter. I am here today to provide a brief overview of the history of our chapter, as well as highlighting some of the resources that may be helpful to you, to the people you serve, to the community, and those diagnosed with ALS and impacting on their families. Our chapter was established in 1977 with one single support group. Our chapter has since expanded to 13 support groups and one online group. We have been the principal charity of the Philadelphia Phillies since 1984. Funding for all direct services and research is achieved through the private donations and through advocacy. The Greater Philadelphia chapter provides services to ALS patients in the following geographic areas: Eastern Pennsylvania, Harrisburg and East, Southern New Jersey, New Brunswick and South, and Delaware. What do patient services do in our chapter? We support and staff 2 ALS certified multidisciplinary teams, both at the Hershey Medical Center as well as at the Jefferson Weinberg Center. We also support and sometimes staff folks at the following clinics, identified as the VA of Philadelphia, Penn, Temple, Lehigh Valley, Geisinger, Bloomsburg, and Wilkes-Barre, Meridian in New Jersey, and the Peninsula Regional Medical Center in Salisbury, Maryland. Some of the services that I'm going to highlight are programs and resources that we can offer to patients and families diagnosed with ALS in our chapter area. We provide a transportation program for individuals that may need assistance with a wheelchair van to access their clinic visits. We also provide a DME loan closet. This is a durable medical equipment warehouse where we provide resources such as wheelchairs, shower and tub chairs, walkers, pivot discs, transfer gates, lift chairs. Oftentimes there are individuals who may not have insurance, or perhaps their insurance may not pay for these services. We also have a loaner closet for what we call assistive technology, gadgets and gadgets, or gadgets and gadgets. And that can be provided via our individual who is our assistive technology individual. We also provide an accessibility program. We often find that patients with ALS may have homes or where they reside are not wheelchair accessible, and therefore a ramp or a stair glide may be something that will make them more functional in the community as well as getting in and out of their home. So we have a program that comes to the home and evaluates whether or not the home is accessible, whether or not this service can be provided to them. Now I'm going to provide our next social worker, Melissa Cole.
Hi, I'm Melissa Call. I'm a social worker with the ALS Association Greater Philadelphia chapter, and I'm going to continue talking about some of the services that we provide throughout our service area. We have our home care program, our Abrams in-home care, which offers up to 12 hours a week of personal care for patients that are living in their own home and don't have any other source of support. You can check with your social worker to see if that's something you would be eligible for. Another home care program that we have is our respite program. This offers up to 24 hours annually of a caregiver for personal care and companionship, and is a great way to give a break for caregivers, for the primary caregivers. Also, through our care services program, we offer home visits from our social workers, our nurses, and also our assistive technologist, Elisa Brownlee, who not only helps with gadgets and gadgets and all the tech things, but also is certified in home modifications, so she can do home visits for that as well. And this is a great way for us to connect with our patients in their own environment and help brainstorm and figure out challenges that they're facing in their home. We also, as Janie had mentioned earlier, provide support groups throughout our service area. We have several support groups where people meet in person once a month throughout the service area. It's a great way to connect with other people living with this disease and their family members. We also offer a couple groups online that are some are for just caregivers and some are for patients and caregivers, and where they can connect either over the phone or through their computer. And this is a great resource for our patients and caregivers. We also have our Visiting Volunteer program, which is a wonderful program that matches volunteers as a friendly visitor for our patients. We also have several recreation programs throughout the year that we host patients and their families. We have our annual Longwood Gardens event in the springtime. We have our annual holiday party. And this past summer, we hosted an event at Knoebels. So check our website, www.alsphiladelphia.org, to see the calendar of upcoming events and sign up for our mailings. We also provide several educational programs throughout the year for our patients and caregivers. We have an annual Caregivers Day to provide support and hands-on skills for our caregivers. We also have WebEx and podcasts that you can access through our website or call in to attend these events on various educational topics for both caregivers and patients living with ALS. And we also have lots of information on our website, which I mentioned earlier, www.alsphiladelphia.org. Advocacy is another big part of what we do here at the ALS Association Greater Philadelphia chapter. Through our efforts with advocacy, we have been able to make a lot of progress in the ALS community. We've been able to waive the 24-month waiting period for Medicare, and we're currently advocating to get the 5-month waiting period waived in applying for Social Security disability. We're hopeful that that will happen soon. And through our advocacy efforts, we've developed the ALS National Registry. We've increased funding for ALS research through the NIH, DoD, and the VA. And through our advocacy efforts, we have been able to work with the VA, and ALS is now 100% service-connected disease. And we've also locally and at the state level have been able to advocate to get funding for care. In summary, the care services team and the social worker is really the first person that you meet upon diagnosis, and we're with you through your journey even until the end, and then supporting the family after. We work to empower both patients and our families, and we do that through the various services that we offer, connecting them with community resources, and empowering them to be a part of their care, as well as advocacy efforts and different things like that. We offer supportive counseling. We do home visits to help support patients and caregivers, and we advocate for our patients and families to get the services that they're entitled to, and also help with insurance issues. So if you have any questions, please don't hesitate to reach out to us. You can reach us at the chapter office at 215-643-5434 and connect with Care Services, which is option number 3. Or you can check us out on our website. Again, it's www.alsphiladelphia.org. Thank you so much.